Today's topic is antenatal care and preconceptional counseling and care. Introduction. Systematic supervision, examination, and advice of a woman during pregnancy is called antenatal or prenatal care. The supervision should be regular and periodic in nature according to the need of the individual. Actual prenatal care is the care in the optimum continuum that starts before pregnancy and ends at the delivery and postpartum period. Antenatal care comprises of careful history taking and examination, general and obstetric advice given to the pregnant woman. Aims and objectives of the antenatal. The aims are to screen high risk cases, to prevent or to detect the treat at the earliest any complication, to ensure continued risk assessment, and to provide ongoing primary preventive health care. To educate the mother about the physiology of the pregnancy and labor by demonstration, charts, diagrams, so that the fear is removed and psychology is improved. To discuss with couple about the place, time, and mode of delivery, provisionally and care of newborn. To motivate the couple about need of family planning and also appropriate advice to couple seeking and medical termination of pregnancy. The objective is to ensure a normal pregnancy with delivery of a healthy baby from a healthy mother. The criteria of a normal pregnancy are delivery of a single baby in a good condition at term with a fetal weight 2.5 kg or more with no maternal complication. Procedures at first visit. The first visit should not be deferred beyond the second miss period. It may be earlier if the patient desires to terminate the pregnancy. Objectives: to assess the health status of the mother and the fetus, to assess the fetal gestation age, to obtain the baseline investigation, to organize continued obstetric care and risk assessment. Component of the routine prenatal care are recorded in a standardized pro forma antenatal record book. History taking, it has a pro forma include vitals, statistics, name, date of exam, address, age, gravidarity, terminology such as nullipara, primipara, parity, primigravida, multigra, parturient prepara should be known. Duration of marriage, religion, occupation of the husband, to anticipate the complication, to give reasonable and realistic antenatal advice during family planning guidance. Period of gestation, to calculate the correct LMP so that we get the correct expected date of delivery. Any use of oral contraceptive previous 3 months prior to conception. Complaints, history of present illness regarding elaborating the chief complaints, their onset, duration, severity, use of medication, progress to be made, history of present pregnancy regarding immunization, number of previous antenatal visits, any complication during the first trimester, any medication or any radiation exposure. Obstetric history, if it is multigravida, the previous delivery, previous abortions. Menstrual history, the cycles, duration, amount of flow, first day of last menstrual period to be recorded. Nagli's formula used to calculate the expected date of delivery from the first day of last menstrual period. Past medical history relevant if any about UTI, tuberculosis, past surgical history, if there any general or gynecological surgery has been taken place. Family history regarding hypertension, diabetes, tuberculosis, blood dysphagia, hereditary disease, if any, or twinning history. Personal history regarding contraception, alcohol, smoking. First ovulation may be delayed for the 4 to 6 weeks, so smoking or alcohol abuse had got some relation with the low birth weight. Previous history of blood transfusion, corticosteroid therapy, drug allergy, NTD. Examination. It includes general examination, build, scene, height, weight, pallor, jaundice, tongue, teeth, gum, tonsils, neck veins, edema of the leg, dependent edema, physiological edema seen. Blood pressure is pulse, blood pressure measured, systemic examination of heart, lung, liver, spleen, breast examination is done, obstetric examination, and the abdomen, tone of the muscles, fundal height. To 12 week, it is below the pelvis. After 12 week, it is just above the pubic symphysis. Vaginal examination to confirm the pregnancy, about the size, development, ultrasound to confirm the findings. Blood investigation, hemoglobin, hematocrit, VRH, blood sugar, VDRL, serology to be done, urine for the protein, sugar, pus, cervical smear for pap smear, special investigation regarding torch, genetic screening for the maternal serum alpha beta protein triple test at 15 to 18 week if there is history of neurotive defect or Down syndrome or high risk for that. Ultrasonic examination by TS or TBS have to detect early pregnancy, accurate dating, number of fetus for the growth fetal anomaly and uterine or adnexal pathology. Use of ultrasound should be selective rather than routine. Booking at 18 to 20 week scan has got advantage. Ultrasonic examination, repetition for the hemoglobin at 28 to 36 week, urine should be tested and sugar to be tested each visit. Procedure at subsequent visits. Generally, checkup is done at 4 week interval up to 28 week, then twice weekly at in once in 2 week at up to 36 week and weekly till delivery. As per WHO, at least 4 visits. First in the first trimester, second in the 24 to 28 week, then at 32 and at 36. Objective is to assess fetal well-being, live presentation, position, number of fetus, anemia, preeclampsia, amniotic fluid volume, fetal growth, to organize special antenatal clinic, to select the time, ultrasonic amniocentesis, history to note appearance of any new symptoms, headache, dysuria, date of quickening, examination, general. In each visit, the following are checked and recording: weight, pallor, edema, legs, blood pressure. Abdominal examination, inspection, abdominal enlargement, pregnancy marks, linea nigra, stria, surgical scar, palpation to note the height of fundus above the pubic symphysis. In the second trimester, to identify the fetus by external development, fetal movement, palpation of fetal parts or auscultation of fetal heart sounds. In the third trimester, abdominal palpation will help to identify fetal lie, positions, growth pattern, liquor. Vaginal examination in the later months of the pregnancy beyond 37 weeks about the assessment of the pelvis. Any vaginal bleeding should examine. Warning sign, any leaking, bleeding, pain, headache, visual disturbances, decrease in loss of movement, fever, rigor, vomiting, diarrhea. Antenatal advice. Principle is to counsel the woman about importance of regular checkup and maintain to improve health of the baby and mother too. Drugs and hygiene, diet, proper diet, optimum growth of the baby. During pregnancy, increased caloric requirement, so the extra 300 calories should be given. Weight, increase in the weight, about 11 up to 11 kg in normal BMI cases. If it is more obese, then less weight. If it is low thin weight, then more weight gain. This is chart showing the daily dietary allowances to be given in certain quantity. Supplement nutritional therapy, antenatal hygiene, rest and sleep properly in the first trimester and last 4 weeks. Recreational activity, bowel constipation is common. So regular fluid and dietary fiber, fluids, vegetable, milk should be taken. Bathing daily, maintain the hygiene, clothing clean, cotton clothes, wear loose, dental care, dental hygiene to be maintained, care of breast, coitus should be avoided in the first trimester, especially in the last trimester. Travel should be avoided in the first trimester and last 6 weeks. Smoking adverse should be avoided as soon as you recognize the pregnancy. Immunization to be done for the tetanus toxoid and live vaccine are contraindicated. Rabies, hepatitis A, B, toxoid can be given in non-pregnant state. Tetanus 2 doses, 0.5. Tetanus toxoid to be given 2 doses, 4 weeks apart, and doses 0.5 ml intramuscular. Women who are immunized in the past, booster dose of 0.5 ml IM is given in the last trimester. Drugs. All the drugs given to the mother will cross to the placenta to reach the fetus. Possibility of pregnancy should be kept in mind by prescribing the drug to any woman of reproductive age group. General advice. She is instructed to report the physician even at early date if some onward symptoms like headache, fever, restlessness, epigastric pain, vomiting, diarrhea happens. She is advised to come hospital for the consideration of admission in following circumstances: painful uterine contractions, sudden gush of liquor, blood, any bleeding. Normal ailments in the pregnancy: nausea, vomiting, backache, constipation, leg cramps, acidity, heartburn, varicose vein, hemorrhoids. Carpal tunnel syndrome, round ligament pain, dialysis, syncope, ankle edema, vaginal discharge. Exercise in the pregnancy. Low impact exercise may be continued throughout the period of pregnancy. Exercise should be regular, 30 minutes per day of low impact. Exercise should avoid any symptoms of breathlessness, fatigue, or dizziness. Exercise should be done in a cool area. Prolonged supine, any compression to the uterus or risk of injury should be avoided. Contraindication to exercise or to limit physical activity: fetal growth restriction, cardiac or pulmonary diseases, cervical insufficiency, vaginal bleeding, hypertension in pregnancy, risk of return. Value of antenatal care. To screen the high risk cases, medical disorder, obstetric complication are sorted out. Detection of high risk factor deserves to no credit unless proper steps are taken to rectify it. Pregnancy should be regularly supervised. Antenatal care said to be strategic. Intranatal care in the tactics in the obstetrics. Acceptance of the advice during pregnancy. Advice regarding diet, drugs, family planning, guidance, immunization schedules are better followed than in non-pregnant state. It is an opportunity to make the patient realize that the childbirth is a physiological process and to boost up the psychology of the patient. The net effect of is marked reluctant in the maternal mortality and morbidity. Drawback. Abnormality may be exaggerated for which unnecessary medication or risk operative interference is prescribed unless quality of care is maintained in the antenatal clinic. The benefit of antenatal care are not obtained. Good antenatal care only cannot reduce the maternal and neonatal mortality and morbidity. Preconceptional counseling and care. When a couple is seen and counseled about the pregnancy, its course, and the outcome well before the time of actual conception is called preconceptional counseling. Objective is to ensure that the woman enters the pregnancy with an optimal state of health, which would be safe both of herself and the fetus. Organogenesis is complete by the first trimester. By the time of woman is seen first in the antenatal clinic, it is often too late to advise because all the adverse factors have been already begun to exert their effect. Preconceptional phase is the time to identify any risk factor that could potentially affect the perinatal outcome adversely. The woman is informed about the risk factor and at the same time is provided preconceptional visit, risk assessment and education. Identification of the high risk factor. Base level health status including blood pressure is recorded, rubella and hepatitis immunization. Folic acid supplementation 4 milligram a day starting 4 weeks prior to conception up to the 12 week of pregnancy advice. Can reduce the incidence of neural tube defects. Maternal health is optimized preconceptionally. Problem of overweight, underweight, anemia, abnormal pap smear evaluated and treated appropriately. Fear of the incoming pregnancy removed by preconceptional education. Patient with the medical complication should be educated about the effect of disease on the pregnancy, also effect of the pregnancy on the disease. Drug used before pregnancy are verified and change if required. So women should be asked to stop smoking, alcohol, abusing drugs. Inherited genetic disease like sickle cell, thalassemia, cystic fibrosis, screened before conception, risk passing to the offspring. Importance of prenatal diagnosis for chromosomal or genetic disease discussed. Inheritable genetic disease could be managed either primary prevention or by secondary prevention, coupled with the history of recurrent fetal losses with the family history of abnormality, genetic chromosome structure are investigated and counseled appropriately. There may be some untreatable factor. Education classes include discussion on regarding delivery, timing, method, and possible interventions. Counseling should be done by primary health care provider. Limitations are there regarding many pregnancy are unplanned, lack of public awareness. Summary of antenatal care. Care for history taking through clinical examination, general and obstetric investigation, routine and special advice, diet, nutrition, hygiene specific to any problem. Subsequent visits every 4 weeks until 28 weeks, then every 2 weeks until 36 weeks, weekly till delivery. Identification of risk factor, maternal health, weight, BP, pallor symptoms, analysis, any other abnormality, fetal health, fetal growth, fundal height, fetal heart rate, native fetal volume, presentation, and fetal activity. Couple education, counseling, and advice. Preparation for the childbirth. Couple is informed about labor post delivery, the need of operation, anesthesia, and complication. Thank you.